Welcome back to part 3 in a 3-part series on neurological emergencies, and we're going to jump right back into history taking. So, history taking is very important in these situations. We need to investigate our chief complaint. For our unresponsive patients, we have to gather any history from family or bystanders. If nobody's around, look for explanations for the altered mental status. So, in these situations, and stroke patients, do they have hemiparalysis? So one side is weak. Did they have a seizure? Are they incontinent? Did they bite their tongue? Ask a representative for the patient. That's a family member, maybe something that if they saw it, if there was a witness or a bystander. Ask a responsive patient what happened. Evaluate the responsive patient's speech. If we're evaluating or talking to the patient and asking them to replay what happened, make sure that they're able to do it correctly. If they have an altered mental status, they may not be able to answer us appropriately. So in our history taking, we need to gather a sample history. Time is of the essence. We need to determine the exact time the patient last appeared healthy. The hospitals, the doctors, the neurologists, they're going to want to know exactly what time it was when this all started. So we're going to collect and list all of their medications. We're going to ask the patient if they have a history of seizures. We're going to ask if this episode differs from previous episodes and what medication that they take. If not, we should suspect that there's a serious illness. In our physical exam, we're doing a full body secondary assessment, and we're paying special attention to the symptom involved, right? Remember our neurological assessments: squeezing hands, checking for equal grips; smile, checking for symmetrical smile; sticking their tongue out, making sure it goes out straight and not off to a side, like that. Yes, YouTube, I just stuck my tongue out. If we suspect that they're having a stroke, we need to direct particular attention to the neurological assessment. So in our vital signs, significant intracranial bleeding leads to a great deal of pressure in the skull, compressing the brain. All right, we need the pulse will slow down, and this will cause erratic respirations. Blood pressure is usually high to compensate for the lack of perfusion. And an unequal pupil size or reactivity may indicate significant bleeding and pressure on the brain. So we need to be aware of all of those things. If they have an altered mental status, check their blood sugar level. During most seizure activities, it is impossible to evaluate vital signs, and we should not be our priority, right? So if they're quivering and shaking all over the place, we can't check their blood pressure. We're not going to get a good reading. So in most cases, vital signs of a patient in a post-ictal state will be close to normal limits because they're relaxed and everything in their body is relaxed as well. Our stroke assessment rapidly identifies stroke in the field with a stroke scale. So what are we doing? We've heard FAST, face, arms, speech, and time. So you need to look up in our book the Cincinnati Pre-Hospital Stroke Scale. That's what we use mostly, right? So do they have symmetrical facial expressions? Do they have arm drift? Is it unequal? Is their speech slurred? And then what time did it start? So we need to get all of those things here. And here's the fast mnemonic. Right, so our Cincinnati Stroke Scale goes over facial droop, arm drift, and speech, and the abnormal and normal responses that we should see. So just pause your screen here, or you can look up Table 17.3 in the book. Table 17.4 in the book is the Los Angeles Pre-Hospital Stroke Scale. We don't really use that, and you're probably not going to see that in your test either. Same thing for the 3-item stroke severity score. In our secondary assessment, we need to do a Glasgow Coma Scale for all patients. So Glasgow Coma Scale, what is it? Table 17.6 in the book, and up here on our screen, we're going to look at the Glasgow Coma Scale, right? So it's 3 responses: eye-opening, verbal response, and motor response. So let's drop right on down to none, right at the very bottom of the list. So in a dead person, somebody whose eyes don't open, they don't respond at all, and they have no motor response whatsoever. Completely dead. They can still score a 3. They will still score a 3. So a dead person is a 3, and it goes on up from there. So in eye-opening, if somebody opens their eyes spontaneously, they get a 4. If they only open their eyes when somebody talks to them, they get a 3. If they only open their eyes in response to a painful stimulus, then they get a 2. For verbal response, if they are oriented in a conversation, they get a 5. If they're confused in a conversation, they get a 4. If they have inappropriate words, and that doesn't mean like foul language, that just means, what's your name? Apple. Apple would be an inappropriate word. Incomprehensible sounds, grunting, moaning, muttering, stammering, not making any sense, like my videos, I would get a 2. And again, none gets a 1. So best motor response, obeys command. Give me a high 5. Okay, I can do that. Gets a sternum rub. I grab at my chest where you've rubbed my sternum. That's a localizing pain. If you give me a sternum rub and I try to pull away, that's a 4. Abnormal flexion would be spontaneous motor movement towards the core, right? So this would be flexion. Abnormal extension would look like this, away from the core. They would get a 2. So 3 towards the core, 4 away. And no motor movement whatsoever would get a 1. So we add them up. Right now, if you want to do a Glasgow Coma score on me, my eyes are open spontaneously, I'm having a oriented conversation, and I follow most commands, although no one's here to command me. I would get a 4 plus a 5 plus a 6, and I would be a 16 for a GCS, right? 15? Wow. My GCS would be 15. At worst, my GCS could be a 3. So that's the Glasgow Coma Scale. Reassessment. Very important for these patients, right? Reassessing ABCs, vital signs, and any intervention we did, right? Because stroke symptoms, neurological symptoms, altered mental status can all resolve or they could get worse. These patients have symptoms that will change rapidly, and we need to kind of be aware of what's going on. We may need to do multiple interventions, airway adjuncts, positive pressure ventilation, or other types of treatment. We're comparing our baseline information with updated information on what our reassessment is telling us. And then again, notifying the receiving facility quickly of the patient's chief complaint and assessment findings. Hospitals want to know very quickly if we're bringing them stroke patients so that they can be prepared. Those patients usually go right away to get a CAT scan. Communication and documentation is important, right? We call a stroke alert to the hospital. All the hospitals that we serve, regardless of their stroke capabilities, will accept stroke alerts, and the patients will get immediate CAT scans. So we need to communicate the time that the patient was last seen healthy, what we found in our examination, and the time that we anticipate arriving at the hospital. For patients that have had a seizure, we need to give a description of the seizure activity if we know. If the patient has a history of seizure activity, how often do they occur? How long are they usually? Things like that. And then document our interventions and the patient's responses to that. So emergency medical care for these patients, some conditions are easier to identify, right? The cause of the neurological emergencies may not always be obvious. If the physician determines that there's bleeding in the brain, the patient's with a suspected stroke with a CAT scan, right? Blood clot dissolving medication may be given if there's no bleeding. So we just pause this, or you can look at table 17.7 in the book. Notify our hospital staff. Treatment are always available if started right away. Communicate the last known time. I can't stress that anymore. Last known time well is very important. Some would argue it's one of the most important parts of our assessment that we can get from a patient. Patients who have had a seizure require definitive evaluation and treatment. Supplemental oxygen is strongly advised, right, because the brain is starved of oxygen. Patients who are having a seizure, we need to protect them from harm. Maintain a clear airway by suctioning. Provide oxygen as quickly as possible. If head or neck trauma is suspected, we need to provide spinal immobilization. Patients who continue to have a seizure, such as status epilepticus, we need to suction their airway, provide positive pressure ventilations, transport them quickly to the hospital, and meet up with ALS, because ALS or paramedics have access to medications that can break the seizure. Most headaches are typically harmless and don't require our care. Usually, if we are dealing with somebody who's a headache, they have some sort of a neurological impairment. Excuse me, I have the hiccups. Always assess the patient for other signs and symptoms that might indicate a more serious condition. Apply high flow oxygen if they can tolerate it. Provide a dark, quiet environment. We might have to lower the lights in the back of the ambulance. Do not use the lights or sirens during a transport. Monitor, support their ABCs to provide a rapid transport to a primary stroke center. Patient may require manual airway positioning, so opening the airway. Use suction as needed and monitor the patient's oxygen saturation. Maintain a pulse ox saturation of at least 94%. These are things that go for all patients, right? Oxygen therapy is not recommended unless the patient is in respiratory distress or is hypoxic. Paralyzed extremities will require protection from harm. Keep the patient informed. Thrombolytic therapy may reverse stroke symptoms, and that's something that hospitals will do. We're not an EMS, we don't do thrombolytic therapy. So for these patients with stroke, spend as little time on scene as possible. It is emergency and time is brain. If possible, transport to a designated stroke center. Seizures. Patient may be in a postictal state when we get there. Assess and treat their ABCs. Administer oxygen if they're having trouble breathing or ineffective respirations. We need to ventilate. Assess for trauma. Use spinal immobilization if it's indicated. Never attempt to restrain a patient having a seizure. Our goal is to encourage the patient to be seen by a physician. They may not want to go to the hospital, but we need to be prepared to discuss the situation with the patient and the hospital staff. Signs and symptoms for altered mental status will vary from simple confusion to coma. Altered mental status is always an emergency that requires immediate attention. Even if the cause appears to be intoxication or minor head trauma, we need to delve deeper into the altered mental status and evaluate them appropriately. So guys, this is the end of the neurological chapter. I strongly encourage you guys to read the vocabulary and understand the vocabulary as always. I hope that you looked at that before we got into the chapter to kind of help you with some of these words. These are words that we use pretty often. We see a lot of stroke patients, so we need to be aware of how we're communicating with other healthcare providers and other EMS people, and that we're using the word correctly. So we kind of lose the ability to go over it and correct each other here in the classroom, but we will meet again in person, I promise you. And as always, I hope that you found this useful, and we're just going to keep plugging along. So again, this is the end of chapter 17, and thanks for watching.